the bell has rung. So get seated and join Elementary Schooled for today's interview.
Hello, I want to welcome back Dr. Jason Hoagland.
Hi.
Thank you for joining us for another episode. Let's talk about attention disorders. They've been plaguing us forever. And actually, I have to say something kind of funny. Every time that I fill out the paperwork for ADHD or just an attention disorder in general, I'm always like, could be. But I also think that, and we'll talk about this, is that our environment creates a lot of, I just feel like we're always multitasking, and sometimes you feel like you have an attention disorder. So we want to talk about distinguishing what really is happening with any person, but namely children in elementary school. So will you talk about that and define attention disorders and just describe them for a minute before we talk about how you diagnose?
For sure. And it's kind of funny you bring that up in terms of when you see that in yourself, because one of the fastest growing groups for prescriptions for Adderall, et cetera, is in adults. And I think the adult onset is kind of a term that's being used, but really it has to be present before you're 12 years of age. But a lot of people are really seeing that in themselves and trying to get some help themselves as well. And so and so ADHD, gosh, this is something that is the largest category of all the mental health diagnoses, and it's something that has a lot of stigma associated with it. You can find episodes on South Park talking about ADHD, very inappropriate, I might add, but ADHD is something that is, very, very funny, but very inappropriate. I'm just gonna throw it out there. So, and the challenge is that I think that people feel like this is kind of a made up diagnosis. And I think I mentioned it in the anxiety discussion, but having not grown up with ADHD in my family and seeing what that looks like, I was always really critical, thinking this was a handicap or a crutch that people were using, until I saw it in my patients and realized how big a deal it was for this child who was smart and had all this potential in terms of intellect. Yet there's this huge gap or dissonance between their performance and their abilities. And that gap was creating situations where they're failing in school, they're struggling with getting homework done, their self-esteem is suffering because they think they're not smart, not good at school, where nothing could be further from the truth, but they're kept from being able to hit their full potential because their brain is unable to shut off the distractions and help prioritize which things are most important. The teacher speaking versus some kid playing with a wrapper over here, some butterfly over there, something shiny. And that's really what defines ADHD, is that there's this gap between ability and performance that needs some help, that isn't going to get better just by counseling in some fashion.
Thank you. It is interesting to me that even though it is common, most people know, have heard of ADHD and with the hyperactive component or just attention deficit disorder, that parents sometimes, when we mention it as teachers, still get surprised, like, oh, I didn't think of that, and I just thought my child was being obstinate or didn't want to follow through with chores and whatnot. And it's almost a relief to them to know that, wow, I just didn't dawn on me. What do you say to that?
Well, and that's the challenge is. And so, and I should expand that a little bit to say that the gap between performance and their ability, that there's really three categories of ADHD that kids fall into. And the first is their focus or attention. And second is their impulse control. And third is their hyperactivity. And so when you see a whole range of what parents and teachers experience in terms of what a child's going through, that they couldn't stay on task, that they couldn't go from one task to the next task, that there's some hope that it's not just their child. And the hard part is when it's your first child and you don't have any other reference point for what should a 3 or a 5 or 7-year-old be like in terms of being able to have executive function and focus on things. And that's where we come in, as we help them and the teachers help them be able to tell the difference between a normal 7-year-old and what their child's doing. And that's what really defines it is how much impulse control, how much focus, and how much hyperactivity a child experiences compared to their peers. And that's what the teachers do, is help parents to have a reference point where teachers see 20 to 30 kids every year over year, hundreds and thousands of kids, and they're excellent at being able to help a mom or dad be able to understand where their child fits compared to other children their age.
Yeah, thank you. And I think it does come with practice because you really can identify it easily. Like I can identify it at church and most places where you're seeing children of a similar age together in a group. And that's usually the suggestion I make to parents if they're on the fence. And I'll say, it would really help if you observe your child around other peers their age and just kind of get a feeling for it. And I always welcome into the classroom because that's one way where they're expected to sit and pay attention many times during the day. That is one place where they really can get a feel for what their child, if they really need it. So how will you explain the process for diagnosing? Because I know teachers really do have a great part in that with the paperwork we do. Will you talk about that?
Sure, sure. So one of the key components of ADHD is that the behavior is present in more than one setting. And so those two most common settings in a child's life are the home and school environment. And so it's so important that we get the input from the teachers to be able to get some insight into that child behavior. We use a lot of different screening instruments and evaluation instruments, and all of them involve some sort of objective assignment of a number to a behavior that's very subjective. And being able to have that observant, caring teacher be able to say, this is what I'm seeing about this child behavior in terms of areas of inattention and hyperactivity and impulse control, makes all the difference in being able to be a reference compared to what the child's experiencing at home. Because sometimes you don't know, is this an environmental situation where it's really chaotic, at home, and so there's not a lot of structure, yet they're wonderful at school. And so being able to really sort out, is this behavior universal or is it very situational? So that's important because we don't want to overcall ADHD and talk about medication for these kids if it's not really there.
Thank you. And I know with you mentioning the three kind of components of focus, impulse control, and hyperactivity, are you saying, they can just have a focus issue and not have the impulse control? Or, I know we've seen definitely many students where they almost like zone out and it is just focus and you won't see the other. So you're saying usually they'll fall into one of those three categories, or can they have more than one?
Oh, 100%. So when you look at the actual diagnosis codes, they have ADHD predominantly inattentive, or ADHD predominantly hyperactive, or what we call combination ADHD, a combination of those. And as most people observe just by looking around, boys are in the hyperactivity and impulse control category a lot more than girls. Girls are in the focus, inattention only category. And as you can imagine, that's why there's a lot of delay in having girls brought to attention to get help, because they're not causing problems in the classroom. They're well behaved compared to those boys over there poking people and doing all these things that say, well, he's got a problem, where that girl is just doing great in the classroom and teachers love them. And they're not being that squeaky wheel, but
Right.
definitely categories of things. And a lot of these kids have all three, especially the boys, but so that combined type is very common, but you can 100% have that broken up into categories and not have all the different components.
Do we know why boys seem to have it more than girls?
Oh gosh, that's a loaded question in terms of, that Y chromosome just makes you do things without thinking about it. And so you kind of act first and see what happens. And that's kind of a Y chromosome thing and part of that testosterone brain. But we just see that that's part of the hardwiring of what makes a boy brain versus a girl brain. Is those boy brains are really motivated towards action. And sometimes it doesn't involve thinking about the consequences. So
Right. Thank you. I do want to talk about the child that does, like I said, kind of get in the zone. So they're not causing it's easier to identify a child that has impulse control issues or hyperactivity because, yeah, they're always out of their seat or have a problem with that or playing with things. But it's the quiet child that isn't causing a disturbance that may go unnoticed. And so we really have to be quite observant. And a lot of times it comes down to, can they finish their work? And that's very taxing for them. They can sit there and they will be so quiet and so sweet, but they are
Yes.
zoned out and thinking about other things. So we see a lot of that.
And I would really pay attention to their performance in terms of repetitive tasks like writing letters and doing their spelling words on a repeat basis. And most of the tests for ADHD and how well medication works involve doing timed math tests and being able to say, what's their rate of completion and their accuracy. And it's interesting that you can have the same questions, same problems on and off medication, back off medication again. You think they would know the answer because they learned that math problem, but it's amazing to see the difference where they don't focus on it. So look at those things in particular, or timed math problems, writing letters repetitively, because for what it's worth, that's kind of boring to them, and so they stop doing it, and or
Yes.
they don't give an effort to it.
Thank you. We see that for sure. And time tests, they still exist, especially with timetables. And
Yes.
so multiplication facts specifically, but we also have computer programs for that. And it's interesting to me that those programs are very stressful to a student with an attention disorder. Sometimes they like that stuff. They like seeing the, the screen move around. But for the most part, it is upsetting to them. And so sometimes that's a sign for us, like, oh, this might be a focus or attention issue. Will you talk about the treatment?
Sure. Yeah. The one thing that really separates out ADHD from all the other mental health diagnoses is that there really isn't a lot of help you can give in terms of counseling. I wish there were more that can be done, but with depression and anxiety, and you have these intrusive thoughts, you have the ability to work on coping mechanisms to move those thoughts off the stage of your mind. But with focus problems, there's no way you can say, hey, when you can't focus, focus. So it's really a challenge to be able to give help to kids when the only tool you have really is medication. There are things that parents can do to help out, but in reality, the mainstay of all treatment for ADHD is a very genetic and very chemical problem, is helping out with medication. But really, you only have medicine. And so there's two categories of medication for helping out with ADHD. You have your stimulants and non-stimulants. Stimulants function much like a light switch, where you turn that light switch on in the morning with a methylphenidate or an Adderall type medication. It works for a period of time, for 8 to 12 hours, and then that light is switched off, and they're back to their baseline behavior. And those are the ones that people know most frequently as far as medications for ADHD. They're very obvious when they work. Teachers say, when the kid comes to school, said, oh, you forgot your medicine today, because they're not doing very well. And then you have some non-stimulant options that function more like a sunrise, where they gradually work over weeks and become more effective. And those work around the clock, not just for a few hours at school. Some examples are atomoxetine and guanfacine, and their action is definitely not as pronounced as the medications that we have that we call stimulants. But yes, it's the one thing where I wish we had other options that we could send somebody for therapy and counseling and not have to just drop the M word of medication or drugs when we talk about this diagnosis.
When you mention the non-stimulant type of medication, is that something you generally try if the parents are hesitant to try the stimulants, or how do you assess which one to
That's
try?
such a great question, because really my job as the pediatrician is to listen to what parents are saying and not saying about what they want to do for their kiddo. They love this child more than anybody on the planet, and they just want to have the best for them. But they may have some reservations about medication, drugs. They hear about all these kind of things, and their potential for abuse and that kind of thing. And so they hear all these stories about medicines. But the problem with the non-stimulants is that they take, like antidepressants and anxiety medication, 3 to 4 weeks to start working. They're not overly obvious. And so we typically start with a stimulant because 80 to 90% of kids will respond to either a methylphenidate or Adderall when you try one and then switch to the other class of medicine. And so you can know very quickly if they're responding, and that response is both a treatment and helps out with that, with really fortifying that diagnosis of saying this child has this problem. They respond great to medication. They can be very focused and do wonderfully with that treatment. So I don't necessarily say, well, if you're on the fence, let's try a different kind of drug, because they can take a long time to get there, and it doesn't necessarily mean it's the best option for them. It's just that it is an option for them, but I tend to hold that in reserve if we're going to be patient for a lot longer to try and find a solution.
I've had, I don't know, maybe a handful of parents over the years that have wanted to try a holistic method, amino acids or whatever. What do you know about that?
Yes, like I mentioned with the anxiety section, I have a certain toolbox that I offer to people, and there are all kinds of alternative offerings for ADHD and discussions about their diet and red dye and different types of things, of taking L-methylfolate and different types of amino acids. And I am 100% supportive of trying normal, healthy, common things, exercise, an overall healthy diet with whole foods and those kinds of things, just to see, because they are definitely beneficial to children. But and I put those out there, but at the same time, when you do all the research on an ADHD, if you have the right diagnosis, then medication is by far and away the one thing that makes a difference, because it just, that child cannot close the door on distractions and
Right.
open the door on what they should be paying attention to, like focusing on the teacher. And so I 100% support people to have a therapeutic journey and say, try these different things, try more mindfulness, and I don't like to use anything that's branded, but brain balance and those kind of things. They tout themselves as things that can be helpful, and there's varying degrees of data saying how helpful they are. But the take home is that I feel comfortable saying try different things, and then if and when you're ready, come back to me, and then we'll talk about medication. But medication is the one thing when we look at all the different counseling and everything else that's been shown to be effective.
Thank you. You mentioned something really important too with that, the follow-up. So when we see them go on medication many times when it's needed, it is a game changer in the classroom.
Yes.
It honestly, you will see scores, and we do a lot of data now with, reading scores. And so we can actually identify specific leaps in their learning. And that is really amazing to see when, wow, he really needed this or she really needed this. And so, but the follow-up is important, because through those growth spurts, sometimes we'll have parents say, we have gone down that road with the attention, and they are on a medication and maybe it's just not working anymore. Is that usually the reason? Is it a dosage issue, or do you have to change medications sometimes?
Oh, that's a great question. And before we did our podcast tonight, I was working with the family on a telemedicine visit with the same question. And the thing about the medications for ADHD is that you never develop tolerance. And tolerance is a physical process where you have to take more medication for it to keep working. And the classic example of that is opioids. The people that get on an opioid like OxyContin will have to take more and more and more to have it work. And so they have to keep seeking higher and higher drug amounts. That doesn't happen with the medications for ADHD. What does happen is exactly the point you brought up, is that they get bigger. And so that dose becomes diluted in this now larger body. And so you need a higher dose for it to keep on working. And so the two competing pressures that you have are, one is that they're getting bigger and may need a higher dose. And so I meet with them every 6 months to make sure we haven't slipped away from being able to have the right amount of medication for them. And so it will always keep working the rest of their life as well as it's working now, as long as you have the right dose. The competing interest is that as they get older and mature, that they may grow out of having the impulse control and focus and hyperactivity issues. And so for me, it's knowing when to take the medications away and working with the parents, and when to increase the dose, because on one end, you may say, well, he doesn't need it anymore. And so we work that out at those visits to make sure we're not treating for too long, but also giving the appropriate medication if more is needed. It's a great question.
Will my child grow out of it? Do they
Yes,
grow out of attention
they do.
disorders usually?
Oh,
Do you
yes,
know?
definitely. So the things that we see are that at least half of the children go on to adulthood with no further evidence for ADHD. Now, that's for a few reasons. Number one is their brain does mature. You can imagine a 2-year-old versus a 20-year-old in their impulse control, the mind type thing, and just if I touch it, it's mine. If I looked at it, it's mine, and very impulse control
Age
driven.
appropriate.
Age appropriate, right? So they get older, and so that impulse control goes away. They also develop more coping mechanisms for their hyperactivity, to know what's appropriate, not appropriate with social cues, and so a lot of that goes away. That medication is not needed to help them to function in their age peer group. So yes, so I would say that about 70-80% don't go into adulthood with medication for various reasons, that they have matured, that they develop social cues and everything else. The medicine is not needed to be successful. But if it is needed, it's important to have them continue, because what was successful in their junior high school years may continue to be help be successful in their college and career.
Thank you. I am glad to know that statistic. I didn't know it was that high, 70 to 80% that grow out of it. That's very comforting. And comforting for parents, because like you said, there's a hesitation sometimes for any of us. Do we want to do this medication? But knowing that this could be temporary, I think that's a very comforting to a parent to know that.
Yeah. And I think one thing that's very important to distinguish in that is that there's two different ways that it's approached. One is there's the kind of self-reporting that can lead to that number being higher in terms of it still being prevalent, versus the strict diagnosis criteria that shows most of have outgrown it. But a lot of people still will quote numbers that it's a lot higher in the adult population, based on the fact that someone self-reports that Adderall helps them to focus. And the problem with that is that it always does. It always helps you to be a little more focused, a little more attentive to details. And so you can't use the response to medication as an indication of how much ADHD is out there, because sometimes those numbers are quoted as being a lot higher than they really are.
It's a good point. I want to ask too, because I know that a frustration that I've heard from parents before is because it is such a controlled substance, that we have to be careful about those medications. And so parents will sometimes say, you know what, we can't always refill it that quickly, 30 days. Is it 30 days? And what do they do about that? They have to kind of, because we can usually tell if a child has been on it, and then all of a sudden it's like, what happened? And they're like, oh, we ran out of medication.
It is a controlled substance. And with that in mind, you do have to be really careful about how those are prescribed. There's a huge amount of diversion, or giving medication to somebody else for whom they're not prescribed. And that's a big problem with those medications. The college campus use of ADHD medications for those who don't have ADHD is really high. And so it's a problem. Let me make maybe one comment about, I think, the either criticism or the challenges people have with starting those kind of medications. I had a parent who was an attorney, and they had a lot of their clients that had been on these types of medications as children, and had a concern that these medications are gateway drugs, that by being on methylphenidate or Adderall, they catalyze the use of other drugs, heroin, meth, stuff like that later on in life. And I said, well, let's think about this. What are the reasons why people that are in jail become your clients? Why are they there? And it's impulse control. They're stealing things, or having those kinds of problems. And so you have somebody who has a lifetime of impulse control. Now, they were on these medications as kids because they helped. And the problem was they stopped using them and had to find illicit ways to help their problems. So methamphetamine is, so meth is, you can get all kinds of things done. And, you have all this energy, but the problem is you lose your teeth, you get addicted, you steal grandma's card to sell her card for money to support your drug habit. But the reality of it is when they have this properly treated, they do well. It's when they don't have it properly treated, that they seek other methods that they find that work for them. And so my advice is to this not to avoid treatment as much as possible, but get appropriate treatment so that you don't have to look for illicit treatments that you might find in some other way later in life. And that can be true of lots of things, where it's marijuana for anxiety and alcohol for depression, that you have an appropriate intervention and they do great. That's when they don't have help, they look for other sources. So
I think that's really important.
yeah, and let me answer one more maybe practical question that I think was in the question you asked earlier, is that we try and do multiple medications for people that we give several months at a time. So it minimizes the start and stop of having 1 month at a time. So
Okay.
hopefully people are engaging with their prescriber to do multiple months at one time. So you have 3 months at a time and then another 3 months at a time. And that's how I do my prescribing for these, so that, again, you have busy moms, dads who don't have time to come to my office every month or call every month to get another prescription. And so we try to make that as simple as possible within the parameters of the law to have as much as we can give them without exceeding what we are allowed to do. So
It is a big deal for these children. I just want to emphasize that if it's needed, it really is a big deal. And there's a lot of patience that goes into nurturing and helping and teaching any child that suffers with an attention disorder. But I see educators all the time that just are trying so hard to work with those students that haven't maybe been diagnosed or into the right hands yet and just need a little help. And they're kind of plugging along, but it's challenging for them. You just feel really bad for those children that really can't control it, that that they're trying so hard and they just can't do it. And so we want to offer that hope to parents and families, again, that you may not have to live this way, to get in the right hands and have a correct evaluation that involves both you and teacher or any observation of their child with their peers. That's really important. What hope can you
yeah,
offer? Oh, go ahead.
well, and no, I and maybe I would almost have a question for you as I think about this, because my understanding is that Utah is really handicapped teachers in not being allowed to suggest that a child has ADHD to a parent. But just your educator observations are so helpful, because they're in this setting that requires so much attention and do the details and tasks, and you see how they're doing. And I think you mentioned earlier is that for you it's really obvious who's struggling compared to their peers in terms of hyperactivity and impulse control. It's not even a question in your mind about which of those children would benefit from being able to have better management of their impulses and their hyperactivity. And so in my mind, and you can tell me how you manage this, but really the parent teacher conferences in my mind seem to be an ideal setting to say, we're seeing that Johnny or Jenny is very smart, has all these abilities. We're really struggling with getting work in and focus. And I don't know how you manage that gift that you have of being able to provide insight without broaching
Right.
the limitations you have, because you're so perfectly positioned to provide feedback.
I would say this: if your child's teacher has hinted around in any way, it is something to take a look at.
Yeah, yeah.
And so the bad news with that, because in recent years, I taught a younger grade and then I moved up to an older grade. And what I've seen and heard from other educators is by the time they maybe get to fourth or fifth grade and they've heard it from several teachers, then they'll say, oh, maybe we should do this. But if it can happen at a younger age, it just honestly makes such an impact, and then they're not playing a lot of catch up and having frustration. But yes, it is tricky, and it's because I get the angle of it that I'm not a physician. I'm not prepared to say exactly what is going on with your child chemically, but we can give pretty good observations and tell that to parents. And so a lot of times we'll say things like, has this been an issue in the past, in terms of your child's attention and focus? Do you see that at home? And again, if we are hinting around, we're seeing it at school. And so I always like to invite parents to come in if they're on the fence and not sure, but when they do it, they see the difference too. And it makes a big difference, not just academically, but behaviorally. They're having more success out on the playground, more success with friends. And so overall, they really do better.
And I think that there's such a self-esteem boost them to realize that I am smart and I am capable. And I just had this barrier placed in front of me in terms of how my brain allows me to focus. It kept me from being successful. And from there on, they just take off and fly. My wife and I were taking a walk the other day and talking about the impact of ADHD. Well, I think we were maybe talking about this podcast I was going to help out with. And I just had a young man. And the thing is, kids that are smart are really funny, because you have to be funny to be smart, to be able to come up with things that are quick and witty and stuff like that. And so I had one young man who was just the class clown. He was funny. People loved him, sitting there third and fourth grade, but just really struggling in school. This is a young man now that has 2 engineering degrees, and he went from being the class clown to being on the little honor roll at elementary school in 1 semester.
Wow.
And that's not a promotion of that drugs are the answer to solving problems. But
Right.
when you have this smart young man in this situation, that his only challenge was he couldn't control his impulses, he still kept his personality. We did prescribing, we did some genetic testing to figure out which medications were best, and he is successful now in as I mentioned, a 2nd engineering degree. And just, and that whole trajectory of his life was changed by moving him from the class clown space to the honor roll. And
I love that.
I've kept his little note from his mom and he, that was his honor roll designation. I still have that from over a decade ago. So
That's really cool. I love those stories. And, I'll just say that an attention deficit child is always smart. They're always smart.
Yes.
They're usually smart and funny. Sometimes it is the coping mechanism. So they are smart and they can come up with the quick wit, but they start really sharing it because that's how they kind of fill their self-esteem, because they can't always do the academic component. So they think, oh, this is where I'm going to find my place in the classroom, which, as you just said, it can kind of get off track, and teachers aren't always appreciative of that. But usually we recognize, oh, this person has a really great gift. Let's just try to channel it in the right direction.
I
And
like that politically correct version of it. It's not always appreciative of their gift. Very good. I like that. Well stated.
Yeah. Well, isn't it Jim Carrey that talks about his
Yes.
6th grade teacher that said, if
Yeah.
you will contain this for the hour you are in here, I will let you have the last 5 minutes. And well, just so grateful when there are some answers. And like you said, we're not trying to promote this. This is for if you are looking for answers and wondering if your child has an attention disorder, to take a look at it and get the teacher involved, get your physician involved. And it is a team effort. So, that saying, it takes a village, that really is true. I do like to end on a little spiritual thought, but my thought was, that scripture that says, be still and know that I am God. I thought about that with attention deficit disorder, because these kids really can't be still. And it is troubling to them in moments where it may be necessary to just be still. Those feelings that are allowed to come in a little bit better if we can be still and not be going all the time. I mean, that's also behavioral for each of us. But if a child really can't do that, it is very frustrating to that little person, and we want to help them.
And isn't that profound? I think also that it does require the ability to be still in order to learn. And I think that if you couple those 2 sentences together of being still, that allows you to know that God is there by being able to study and learn and ponder, versus just being too busy and just too wiggly to be able to have an experience that allows you to learn. So that's a wonderful set of sentences to finish this up.
It's a good reminder for me too, thank you so much. I think this will
You're
be
welcome.
very beneficial to families, parents, and educators.
Well, thanks for having me.
Thanks for being part of today's class. To submit a question or topic for further episodes, please email elementary.schooled@outlook.com. School is out for today, but please remember, when we strengthen a child, we strengthen society.